Thank you all for joining us for today's conversation about COVID-19 in Idaho. I'm Ian Stevenson, public health reporter for the Idaho Statesman. Since our last COVID event in August, Idaho has been through its worst period of the pandemic. For over 9 weeks starting in September, many hospitals in the state had more patients than resources to care for them, largely due to an influx of unvaccinated COVID patients. It was Idaho's deadliest period of the pandemic, with more COVID patients in intensive care than ever before, and those patients were getting younger. Now, with the winter holidays upon us, Idaho is facing a new potential threat, Omicron, a variant that may spread more easily than the dangerous Delta variant. And while only one case of Omicron has been detected in Idaho, health officials believe there are more coming. After falling quickly throughout November, case rates and the positivity rate in the Gem State have more or less plateaued. So in short, there's much to consider, and I can't think of three better people to discuss it all with than our guests here today. Joining us from the Division of Public Health is our state's epidemiologist, Dr. Christine Hahn. Dr. Hahn is board certified in infectious disease, while also serving as a non-voting member on the Center for Disease Control's Advisory Committee on Immunization Practices. Also joining us is someone you may recognize from our previous live events, Dr. David Pate, the former president of St. Luke's Health System and a member of the governor's coronavirus working group. He co-authored a forthcoming book called Preparing for the Next Pandemic: Lessons, Stories, and Recommendations. Lastly, we are joined today by Dr. Christopher Ball, the director of the State Bureau of Laboratories. Dr. Ball also serves as co-chair of the governor's coronavirus testing task force. Welcome to all of you, and thank you for joining us. I'm going to begin by asking our guests a few questions, after which we will turn to audience questions, which many of you watching submitted when you registered. If you have a question and would like to ask now, please post a comment on the Facebook or YouTube video streams, and I will get to as many as I can during the second half of today's hour. Let's get into it. Dr. Pate, I'd like to start with you. The holidays are fast approaching. Should families be changing any of their plans because of this new variant, or because the youngest children are still not eligible to be vaccinated?
Well, I don't know that it necessarily requires a change of plans, but it does require people to be very careful and consider how they plan for a get-together. So, it involves assessing what are the risks of yourself and your own family members, what are the risks of those that you're going to be with, what is the level of disease activity wherever you would be traveling to, and how are you going to protect yourself during those travels if that involves public transportation and all. Another thing we have to add to the equation is if you're traveling somewhere where there's currently a high level of disease transmission, you need to also go further to check, are those hospitals there overwhelmed? Because you need to have a plan if you're traveling and especially taking a child. Sometimes children just get hurt. It doesn't have to be COVID, but where would you go? Would hospitals even be available for you? So there's just a lot of things to consider. And certainly with a lot of uncertainty and the rise in Omicron that we're invariably seeing, it does mean think extra hard about those who may be at special risk: older individuals, people that aren't vaccinated, people who have not yet gotten their boosters, people that have underlying compromising conditions. There's just a lot of factors to take into consideration. We want people to enjoy their families, but we also don't want any bad outcomes of that as well.
And Dr. Hahn, a question for you. Since Omicron was quickly designated a variant of concern last month, scientists around the world have rushed to study this new strain and nail down its properties. As of now, what do we know about Omicron and what are we still unsure of?
Yeah, thank you. That's a really important question. And I think if you ask me that question 3 days in a row, I'll have to give you different answers. It's really changing that quickly. As of this morning, what I think we know, there are a few things that we do know. One is that this variant is spreading. It appears to be, I think, the growing consensus that it appears to be more transmissible than Delta or the previous variant. So, the numbers vary depending on what country you're talking about or what report, but it seems to be 2 times or 4 times more transmissible in some reports. So definitely it's very catchy and it is moving quickly. We see also that it has, especially in the United Kingdom, really good data was shared yesterday by CDC showing that it, when they compare it to how quickly Delta rose in the United Kingdom, it is rising faster than Delta. And I remember at the time we thought Delta came very quickly. So I think that's pretty concrete. How severe it is one of the things that we really don't know yet. I think people are fairly confident it doesn't appear to be any worse than Delta as far as we aren't seeing hospitals immediately getting overwhelmed. We're not seeing reports of a lot of fatalities. United Kingdom just reported their first death, I think it was day before yesterday. So we're not seeing a lot of evidence that this is going to be a very severe disease, but there are several caveats to that. One is that it is early on in this wave, and we really are gathering data and seeing as we go. Secondly, folks in South Africa are different. The virus and the dynamics are different in other countries than they will be in the United States. One reason is that in South Africa, they've had their own unique strains and variants circulating there that are a little different. And so they may have a different level of immunity, baseline immunity, than we do here. Their vaccination rate is actually lower, but the initial outbreaks in that population were in young, healthy people. We don't know how it's going to impact elderly in the United States, for example. So a lot of things we don't quite know yet about severity, but at least some reassuring initial data. I just want to be cautious not to be too over the top that this is going to be a mild infection for almost everyone. We aren't sure about that yet, but that's good news. The other areas I want to touch on briefly, one is vaccine. We know that people who've had the vaccine in the laboratory, at least when they look at their antibodies from those folks, they have some protection, but not nearly as good protection as they do against the Delta. Now, on the other hand, for folks that have been boosted, that protection, again, lab data only, but that looks really good. So that's one reason why you've heard us talk about boosters even more in the last few weeks. This Omicron is suggesting how important it is for folks to get their booster and not rely on just the primary series. For people that had natural immunity, if you will, that have been infected before and are saying, well, I understand that I'm pretty well protected. The question is, that's true because we've had Delta circulating for long enough now that if you had a Delta or even some of the earlier variants, you appear to be protected against Delta. But again, in the lab, doesn't look like it's so good against Omicron. So people that have been relying on that should think about getting vaccinated if they have not to date, because the Omicron is going to be quite different. Lastly, treatment, and I'll just mention the monoclonal antibodies and the antivirals. The monoclonal antibodies, there are 3 products out there that we've been using in Idaho and around the country to help people who already have COVID, have high risk of getting very sick, getting in the hospital. And we have treatment centers set up throughout the state. There are some clinicians and some health systems treating their own patients as well with these monoclonal antibodies. It looks like those might not work as well. From the manufacturers have reported this, that 2 of the 3 don't appear like they're going to work very well. The third one, which is by GSK, and it's called Sotrovimab, that one looks like the company's reporting they think it's going to do okay. So we are glad that we've got these 3 options and that one of them might actually be effective. Antiviral medications, which are not yet out there, they're pending. We keep thinking any day we'll have those hopefully to start distributing, one by Merck and one by Pfizer. The companies believe that they should work against Omicron. So we do have some tools, but we've kind of lost some other tools. Long answer, but there's just a lot of things to consider.
Do we have a sense of what the timeline might be for those antiviral pills that you just mentioned?
Sure. Yeah. The molnupiravir is the first one that we are expecting. That has already been authorized by FDA. We're just waiting for that to get the thumbs up from the federal government that we can start putting orders in. So we've got partners in place for that. We've worked with some of the large pharmacy chains where we want to make sure throughout the entire state these will be available. We're thinking any day we will be told we can start putting in orders for that. The second one, the Pfizer product, has not yet been granted authorization by the FDA. So we got a little longer of a wait there, but the data from them looks fabulous. And the expectation is that will get authorized in the really coming days and weeks.
Thank you, Dr. Hahn. Dr. Ball, a question for you. Omicron has now been detected in, by my most recent count, at least 38 states, including Idaho. and CDC modeling indicates that its prevalence nationally increased 7-fold last week over the prior week. How much do you think Omicron is currently spreading in Idaho as compared to Delta?
Well, Ian, that's a tricky question to answer with a high degree of confidence. I think when we look at our variant surveillance program, there's a few considerations that we need to think about. One is we're limited to being able to detect variants only by sequencing positive samples that have been tested using a PCR or other suitable molecular test. And that's a decreasing percentage of the number of total tests that are being done in the state right now, as there are new over-the-counter or rapid tests that are more convenient for people to use. That being said, of all of the PCR tests that come in, we don't have the ability to sequence all of those, but we are currently sequencing on average about 10% of those, which if you look at some of the sort of mathematical projections should give us a really good degree of confidence that we can detect the Omicron variant if it's circulating at 1 in 500 or 1 in 1,000 samples that are sequenced, which is a pretty good rate. So I think that we have the infrastructure in place to be able to detect Omicron as it comes into the state. And if we look at the relative rise that we've seen in other countries as it's started to gain foothold, I think that if we see similar rates of increase, we should be able to detect that pretty quickly. I think another point that's really important to note is that along with the other good news that Dr. Hahn was talking about, almost all of the currently authorized tests, both the nucleic acid amplification tests or molecular tests, as well as the antigen tests or rapid tests, are capable of detecting the Omicron variant. So I think in a testing sense, we're in a very good position to be able to monitor how Omicron comes into the country and comes into the state and be able to determine if it's going to be able to sufficiently displace Delta or whether it's going to coexist with Delta. At this point, we just really don't know what it's going to look like in Idaho.
Thank you. Dr. Hahn, another question for you. Idaho hospitals spent many weeks in crisis standards of care this fall with not enough resources to deal with the influx of patients that they were seeing. How did crisis standards of care affect future hospital preparedness? Will anything be different if the state needs to activate crisis standards again?
Yeah, thank you, Ian. You know, I, of course, don't work for the hospitals, but we are on calls every day with them. So we certainly hear from them some of the challenges on a daily basis that they're facing. I know Dr. Pate will have some insights as well with his, former role at St. Luke's. But I'll tell you what we're hearing from the hospitals right now is that, first of all, they're exhausted. So it's kind of like they're coming, to the end of the marathon as far as crisis standards of care, but they got to keep going. So there's sort of a sense of loss of reserves, and you're hoping to take some time off at the holidays. So more staff are asking for time off. Staff have left and quit because it's been too much. And so they're already at the end of their reserves. And then in addition to the looking at the Omicron wave possibly coming, which is discouraging, they also have a huge backlog now of surgeries and other less urgent medical care that's been put off that they know they're facing, and a lot of patients that have been waiting patiently for to get that care that maybe wasn't an emergency, but that really impacts their quality of life, and really that type of care needs to be done as quickly as possible. So I feel like they're in a really tight spot. I know that with the news it's great that most of the state is now out of crisis standards of care. We're hopeful that Kootenai and the northern Idaho is also going to be coming out of crisis standards of care very soon. But in the meanwhile, we think that people are going to think, oh, good, everything's back to normal. And it's almost harder for them because that's the expectation now that things are back to normal. But they have this huge backlog and this fatigue that they're going to have to deal with going forward.
Dr. Pate, would you like to add anything to that?
Yeah, that was a fantastic answer from Dr. Hahn. I'll just add two things, one good thing and one bad thing. The good thing is because we've never done this before, and so we've learned a lot, and we've tried a lot of innovations. And, the audience may not think it's a big deal. Well, if you have to create new space, in a classroom or in the waiting room or something, how big a deal is that? It's a big deal because a lot of these patients are requiring high flow oxygen, and typically you can't keep that up easily with just an oxygen tank. So you need medical plumbing, gas plumbing. You need ways to monitor and see people. And so our ICUs are structured in a way so that nurses can have visibility to monitors, hear monitor alarms, see patients, and that's tricky. So I could go on, but suffice it to say, it's not that easy, but we've learned a lot how to stretch when we need to, how to get innovative about it. I'll just add on the bad note, what Dr. Hahn was talking about with the risk of Omicron creating an infection, not severe disease, but an infection in somebody who's either previously been infected or who's been fully vaccinated. We do have to worry about our healthcare workers, and because they typically were kind of front in line for vaccination, so they've had it the longest. So it's really important that they get boosted. But what the concern is, if in fact a lot of the healthcare workers do get these infections, even if they're mild, we still have to take them out of the service of patients. And if Omicron really does spike, and we don't know whether it will or not here, but if it does, that could be a major impact on our nursing staff, doctors, and others. So that's another concern.
Thank you. Sort of going off of that, Dr. Ball, like other viruses, we've seen the coronavirus mutating and changing over the last 20 months. Now we have this Omicron variant. Why in general do viruses evolve, and what are the trade-offs that occur when viruses do change?
This is a really good question, Ian, and I think that there's a number of things that we can consider. So there's really 4 things that I guess to me are really important to consider. One is, if you look at what the life cycle of the virus is, it needs to be able to do 3 primary things. First, it needs to be able to enter and evade the primary defense mechanisms, the skin, the mucous membranes of the host, and attach to a receptor so that it can get into the cell and it can replicate itself. And then when it leaves the cell, it needs to be able to both evade our immune system and effectively get out into the environment. And then it also needs to be able to persist in the environment long enough to find a new host. Those are the 3 big challenges that viruses need to try to solve. So with the big environmental problems they need to try to solve in order to continue on and be successful. So as any virus is replicating, it's copying its genome, it's going to make mistakes. And I think what a lot of people don't realize is that the only viruses that we actually see and detect are the ones that those mistakes weren't too detrimental. So we never see any of the failures. We only see the successes. The success stories from the virus standpoint are those that are able to sufficiently answer those questions. Can I infect the cell? Can I replicate? Can I survive in the environment long enough to get to a new host? And so what we see over time is that each cell that gets infected creates tens to hundreds of thousands of copies of itself. And in every one of those replication events, there can be errors that are made. Some of them are detrimental and the virus doesn't survive. Some of them may confer an advantage and it helps them replicate faster. It helps them survive in the environment faster, or it helps them evade the immune system faster. And that's really the play that we have between the virus and the person that's infected, this constant interchange of the virus trying to shift and solve those problems that are being presented to it, and the body trying to adapt to be able to respond to those changes that the virus is making. I think with regard to Omicron, what we're seeing and what got scientists so worried was that the sheer number of changes that they observed in Omicron was unlike what we've seen with variants prior to that. And so the vast number of changes, predominantly in the area where the virus attaches to the host cell, is what's giving us problems both with the sort of lessening immune response or immune evasion of the Omicron variant. And also it seems to be making it more transmissible. So it's able to attach to cells faster, it's able to replicate faster, and it's able to disperse faster. And there's also some literature out there that would suggest that it may persist in the environment a little bit better too. So it appears that this virus, although lots and lots of information still to come on it as scientists study it, it may have found good ways to address all three of those big aspects that the virus needs to address in order to be more successful than, say, the Delta variant or previous variants.
Dr. Hahn, sort of related to what Dr. Ball was saying about how these viruses change. With 2 years of data in our pockets, we've seen now multiple waves of rising COVID infections. And some experts have suggested there may be a seasonal element to the spread of COVID, as there is with many other diseases, but others caution that there are other potential cycles or more important factors involved in how these viruses surge or decline. What have you learned about how these surges operate and other ways that we can fight COVID with this new knowledge?
Yeah, thank you, Ian. That's a great point. As we talk about, are we still in a pandemic or is this becoming endemic? One of the things that virologists really are looking for is if it starts to fall into a routine pattern. Obviously, you can only see that over years, right? So it's hard to know right now. And one of our best studied examples, of course, that we keep looking back to are the influenza pandemics of the past. And what influenza tended to do was both in the 2009 and back in the 1918, some of the more recent pandemics, but also some of the older ones, is a spring wave, which is an unusual time for flu, right? Everybody's like, whoa, what's happening? We're supposed to be getting over flu, not getting a wave. And then a little bit of a calm and then a return. And then it just not acting like a seasonal virus, acting unpredictably and in waves that are faster than what we would normally expect, which might be almost like an annual type of cycle. There are other viruses that do that too, right? Other viruses that we think of as seasonal or, winter viruses, that kind of thing. RSV is a classic one too that we usually don't start seeing until November, December, and kind of lasts through much of the winter. So when we start to see viruses, a new virus, we are waiting for it to start showing us that it's going to behave, normally, that is a predictable cycle. So what we've learned, so back before COVID, when we would do flu pandemic planning or pandemic planning, but we would always kind of use flu as our example. That was often stated, we will probably see multiple waves of this. It won't just be a one and done. We were hopeful, of course, that would be different with coronavirus, but clearly it's showing us that it can do unpredictable cycles. So where I feel we're at right now is we, of course, are worried. We saw a big wave last winter. Even if we don't see as big of a wave, we know that we will likely see influenza in addition to it, plus other seasonal viruses. And so we're concerned about the overall burden on hospitals, even if the Omicron turns out to not cause its own severe hospitalization wave. So I would say, again, too early to say for sure, but in my mind, most people that are studying and following this virus say it is still acting like a pandemic virus. It is not predictable at this point. Nobody's saying with any confidence what's going to happen this winter. People are providing guesses and forecasts and, models that might suggest one or the other. Nobody knows. So maybe by next fall, if we see a winter wave and we don't see any activity and then start to see activity next fall, we can say, okay, it looks like it's starting to act like a seasonal respiratory virus, but we're not there yet.
All right, I'll ask one more question from me and then we'll get to some listener questions. Dr. Payton, this is sort of, I guess, gets more to the social dynamic of this pandemic. Misinformation and disinformation have plagued our ability to fight this pandemic from the start. Are there particular bits of incorrect information or narratives about COVID that you've noticed recently taking hold that you'd like to correct the record on?
Well, there's no shortage of examples or amounts of disinformation. I think that probably the most frustrating for all of us is a lot of the disinformation about the vaccines is because if we want to have disinformation about there, is this worse than the flu or that and all, that's one thing. But the disinformation about the vaccines is causing people not to get vaccinated, and it's putting them at risk, and it's putting our society at risk. So I think those are the big concerns. And I think the most common frustrating refrains I hear about vaccines. First of all, there's a lot of people that misuse the data in a national reporting system where people can self-report events that happen after vaccines. And one common piece of disinformation is thousands and thousands of people have died from the COVID vaccine. And that's not true. And where they're getting that is they're saying, well, every death reported to this system called VAERS is because of the vaccine. Well, that's not true. You have to remember that in this country, if you have 330 million people, go back before COVID, you still have thousands of people that die every single day. It's just, you have thousands that are born and you have thousands that die. And so you can't look at that and say, oh, because somebody died, that the vaccine killed them. And when the CDC and the FDA look at this data, in fact, it is quite extraordinary when somebody has a death related to the vaccine. We only have, a couple handful of examples of that. So that's a big thing, because you're just scaring people when you say that. I think the other, and there's many examples, but I'll give you one more example, and that is there are people alleging that the vaccines are causing cancer. And we had someone suggest that we've had like a 20-fold increase in cancers all of a sudden since the COVID vaccines. Well, first of all, it doesn't really make sense, because typically things that cause cancer, you have to have a pretty prolonged exposure to it. And this would be really shockingly early for cancers to arise from the vaccine. And we've never had cancers develop from any other vaccines. And nobody else can show an increase in cancer. So this is clearly not correct, but it's scaring people. And when in fact, we have had more issues from the virus causing problems than we have from the vaccines. So, one of the common problems is people aren't putting the perspective in place. Are there some things that can happen with the vaccine? Yes, you could get myocarditis and all. Okay. Well, the point is not, do I get vaccinated and take a chance on getting myocarditis, or do I not? The question is, if I'm going to encounter COVID, do I want the myocarditis that comes from the infection, or do I want this really, really small chance of myocarditis from the vaccine? Well, the clear answer, if your objective is, you would prefer it be from the vaccine, and because those are very mild. They really occur mostly in men, mostly in young men, and they're not consequential in most cases. They're very mild. Whereas COVID itself causes much more problems with heart than that. So I think the biggest problem is the disinformation and the misinformation about vaccines.
Thank you, Dr. Pate. I'm going to go to some reader questions now. And again, a reminder, if you're watching and you have a question, please post it in the Facebook comment or YouTube comment on the links. So here's a question from Dana in Boise, perhaps for Dr. Ball. How often can we expect variants? And is it similar to how often new flu strains come around?
That's a really good question. And it's a very hard question to predict. So one of the things that I think people don't realize or don't think about is that every time we sequence a SARS-CoV-2 virus and we analyze that, we do get a lineage designation. We get a name for that variant or that virus. And there are hundreds of thousands of different lineages out there, many of which are not the ones that we're either terming a variant of interest or a variant of concern, because the clinical disease manifestations aren't as worrisome as they are with these particular variants that we're seeing within Omicron or Delta or Alpha or Beta, some of the other named variants of concern. And so as I was addressing before, these viruses are changing all the time. The vast majority of the changes don't really make any significant difference in the course of the disease. It's only those where we have either increased transmissibility, increased ability to evade the immune response of the body, or increased severity of illness. Those are the ones that we're very concerned about. And it's very difficult to predict when those mutations may arise because they're happening randomly. And as I mentioned before, most of the mutations that arise we never hear or see or know about. And so it's very, very difficult to forecast in the future when we may see another variant of concern emerging.
Thanks. And here's a follow-up question, I guess, from Heather, also in Boise. Is COVID and its variations just here to stay? I thought that variants and mutations of a virus were supposed to fade in strength over time, but it feels like this virus keeps getting scarier. Is there research into how the virus is mutating, behaving, and evolving that might give us any type of reprieve or reassurance?
You know, that's a great question, and I'll definitely take a first stab at it, but would invite both Doctors Pate and Hahn to contribute as well. One of the things that we're going to see is that as long as we have sustained and active transmission of the virus, then we're going to have pressures put on that virus in rapid succession to be able to try to identify new and better ways to infect people and to replicate and survive in the environment. So really the key to trying to limit how much this virus changes is really trying to get the pandemic under control and minimize the amount of transmission and minimize the amount of interaction that's happening between the virus and people. So the longer we can allow it to spread and transmit in an uncontrolled fashion, the more likely we are to see new variants with concerning features arising. There's really no way we can predict what's going to happen with this virus in the future, and whether it will start to cause worse disease, it will have more mild disease, whether it become more transmissible or less transmissible. We really don't have any way to predict that because the mutation process is entirely random in nature. And certainly I would welcome any comments that Dr. Pate or Dr. Hahn have on that as well.
Sure, I'll just say a few words, and Dr. Pate might want to also. I think, and I feel I understand the confusion with the question, because I had that, I'd say, misperception now as well in the past. That is that viruses, as they continue to pass through human to human to human to human, tended to get milder over time. And I think to go back to what Dr. Ball said earlier, I think the truth is, and I think we're all better at communicating this now, viruses succeed more by those three steps that Dr. Ball talked about. It's really about, can they get in the person or a host? You know, we're talking about people, so I'll say person. Can it multiply? Can it get out there to get to somebody else? Whether it makes you sicker or less sick, the mutation is not driven by that. We used to say, well, it doesn't want to kill you because it really wants to get to the next host. But nowadays, that's a fine way to spread if you're going to get really sick, because, you know, unless proper PPE is used all along, you're still around other people, they're taking care of you, you can still spread it. Or if you're mildly ill or you're asymptomatic, you're going to potentially spread it. And that's why we talk so much about masking, because the virus doesn't care that much if you're sick or not. We think of viruses that have been around a long time and haven't necessarily gotten milder over time. So just to kind of reemphasize what Dr. Ball said, it's really about can the virus do the things better that it needs to do to survive and spread.
Yeah, I think Dr. Hahn and Dr. Ball said this very well. In this case, it's very important to understand that what is giving this virus a huge advantage is the time from when it infects you to when it becomes infectious to when you develop symptoms to where you get really sick and or die. And you've heard us talk many times about hospitalizations lag, deaths lag. If this virus infected you today and you got contagious in 2 days, but you also ended up profoundly ill and were in the hospital or you died, it would have trouble spreading because you're killing off the host. But that's not what happens with this virus. And what's particularly challenging about this virus is what Dr. Hahn just said, the fact that you can be infectious for days and not even realize that you're infected, especially younger people. And we've had lots of people that were infectious even though they had no symptoms. And we had other people that were infectious and they had some symptoms, but they might have thought, well, I've just overdone it. I haven't gotten enough rest, or maybe my allergies are acting up, but it turns out it's COVID. And that really helps this virus spread. And I think to Dr. Hahn's point, think about viruses that we've had identified around for decades that are not any milder. Ebola, HIV, measles, hepatitis viruses. There's plenty of viruses that we can point to that people think there's that general rule that with time viruses become milder. It could happen, and that would be fantastic, but many exceptions to the rule.
We've got a question now about monoclonal antibodies from Gary in Meridian. If I have not had the shot or COVID and get treated with monoclonal antibodies if I do catch COVID, will I have natural immunities after those treatments? Perhaps Dr. Hahn?
Yeah, I'm happy to take a stab at that. First of all, of course, we would prefer you get vaccinated. One thing I just want to make a quick point, since we're talking about monoclonal antibodies, is there aren't enough of them for everybody. If we all relied on those, there aren't enough. We are fortunate to have them, and we encourage people to, especially if they are at high risk of severe illness, to seek monoclonal antibodies. Talk to your provider. There are locations throughout the state where you can get treated. So it's important. And those monoclonal antibodies will give you good protection. We talk about for 90 days, for example, if you do get monoclonal antibodies, don't bother getting a vaccine for 90 days because essentially your immune system, those antibodies will come in and they'll actually make it hard for that vaccine to have the effect it's supposed to have. And you probably get a little trail off protection even longer. But that said, you will, if you get treated with monoclonal antibodies and you have natural infection, I haven't seen yet the data to suggest how much residual natural immunity. I think part of that would depend on how quickly you got treated. If you got monoclonal antibodies, you can even get it post-exposure in some cases. Let's say you're at high risk and you find out your spouse has COVID and you're very concerned. You could potentially get monoclonal antibodies before you even get sick. In that case, I doubt after those monoclonal antibodies wear off, you probably have no residual natural immunity left. If you wait, though, and you've been sick for several days and then you go in and get the monoclonal antibody treatment, I think it's likely your body will have already developed some natural immunity that will persist afterwards. But I haven't seen any data on that. That's just kind of thinking through the way the body works.
Thank you. Here's a question now about the state of COVID in Idaho from Donna. Is Idaho experiencing a surge in cases as Eastern American states are? And what's the situation in different parts of our state?
Ian, you didn't direct that to anybody. I don't know if you want me to I can tackle that if you like.
Perhaps Dr. Hahn, would you maybe perhaps?
Yeah, real quickly. So basically, we are not seeing a surge yet. We are concerned. When you look at our numbers, they were coming down. They were coming down really since late September. We've kind of seen some improvements over time, but that has flattened out. And what that makes us worry about is that we're flattening out and we're going to start seeing a rise. But right now, thankfully, we have not seen a surge.
Dr. Pate from Megan in Meridian, she asks, is it safe to vaccinate my new 5-year-old or newly turned 5-year-old? What are your thoughts on my 2-year-old when a vaccine is authorized for that age group? She says we wear masks and limit our exposure to others.
Well, good for Megan. That's great. First of all, I highly recommend vaccinating children. Some people will say, well, why should we vaccinate children? Because they don't tend to get very sick or die. And that is in general true. Now, there will be children that do get sick, and God forbid, there have been deaths in children. So certainly we want to protect children. But the main reason for vaccinating the children is that they're one of the biggest sources of spreading this disease, especially now that it's become much more transmissible. Because what do? They go to schools, they're in large groups for long periods of time. In many of those schools, not everybody masked, not able to keep distance. So, schools are a great place, but kids do other things that put them at risk. They have sleepovers. They have a lot of potential risks. And what we can do by vaccinating them is we can interrupt more of this transmission chain. And so back to Dr. Ball's point, if we want to slow down the development of these variants, we have to slow down the transmission. And you really can't do that without including kids. The added benefit is that it is going to help protect kids. And, even here in Idaho, we've had 150 kids in the hospital over the course of this pandemic. That's a small percentage, but ask those perhaps 300 parents if that was a trivial thing or not, because it's very scary. So yes, get your 5-year-old child vaccinated. I have advised all my grandchildren to get vaccinated. You're going to have peace of mind. If you plan to travel, good chance that, that your kid not being vaccinated is going to interfere with that. A lot of other activities you might do. And then the other point is mentioning that 2-year-old who can't currently get vaccinated. The more people in the family that do get vaccinated dramatically decreases the chance that person who can't get vaccinated, like that 2-year-old, or let's say, that the mom in the house is going through cancer treatment for breast cancer, or let's say grandma or grandpa is elderly and frail. The more people that get vaccinated, you dramatically drop the risk that those vulnerable people are going to get infected. So that's a great way to protect your family.
Based on the data that we've seen so far about Omicron, is there any indication that the risk to children is different with this new variant? Perhaps Dr. Pate or Dr. Hahn or...
Not that we've seen so far. There is a bit of a concern because, you heard Dr. Hahn discuss what happened in South Africa, but early on, South Africa was reporting 11% of their admissions being in children under 2, which is very surprising to us. And I don't think we've figured that out unless Dr. Hahn or Dr. Ball have heard something new. I'm not sure if this is something peculiar to South Africa. Maybe they have a lower threshold to admit children or something, because we haven't seen that anywhere else where children are getting disproportionately harmed relative to adults or anything, or prior variants. So we don't think so, but I certainly do want to throw out some caution that we're still learning about Omicron. There's still a lot we don't know. And as Dr. Hahn said earlier, because of a lot of different circumstances, it could behave differently, better or worse in the United States than it does in another country.
Dr. Hahn, did you want to add something to that, or?
Yeah, no, I'll just second that there was some initial concerning evidence from South Africa about more hospitalizations in young children that were concerning. And so far that hasn't borne out yet, but it's still early. So I totally agree with that message. Too early to be sure. We're keeping a very close eye on it because we know how concerning that would be, especially if they were children too young to be vaccinated.
Michael in Boise asks, and I know, Dr. Hahn, that you don't have a day-to-day report necessarily on this, but in recent months, what percentage of hospitalized patients were unvaccinated?
Yeah, so I'll start off with an anecdote and then I'll tell you what our data says. If you talk to doctors that work in hospitals, I had the opportunity to meet with physicians at St. Luke's recently, and they say that almost all the patients are completely unvaccinated that are in the hospital. The people in the ICU and the people that they see that die are unvaccinated. Our state level data says in the hospital, about 88% of them are unvaccinated. So I think no matter which way you look at it, it seems clear that that the folks that get severely ill are usually unvaccinated. And those that are vaccinated, in a lot of cases, are folks that we already know the vaccine may not always work as well, either immune compromised or advanced elderly. And that's why we're pushing so hard on the boosters right now to try to get those folks better immunity.
And Ian, I might just add that in addition to that, that's also what we're hearing from other countries that are having big spikes in Omicron right now, like Denmark. They're still reporting that pattern, that the vast majority of those people that they're hospitalizing or putting in critical care right now, even with Omicron, which is their percentage of Omicron is very, very high, they're still predominantly unvaccinated.
Thank you. Dr. Ball, a question for you from Barb on Facebook, who asks, are we safe attending services at St. Michael's now that we can only open the doors but not the windows?
Well, that's a good question. I think that we can expand beyond just one facility. As we start looking at coming into more congregate settings, I think it's very important that we continue to follow the tried and true public health intervention steps that we've been following since the beginning of the pandemic. And that's try to our very best to enable distancing, wear our masks, have good hand hygiene, and where possible, if you can increase ventilation in a building without making it incredibly uncomfortable when it's 30 degrees outside, then that helps move and circulate air through the facility, and that helps push viral particles that may be in the air out of the building and lower the risk of transmission. So I think it's really a measure of we need to stick with, even though we're all very tired of it, some of these mitigation strategies that, while seemingly controversial, have proven to be very, very successful, even though they're very simple things to follow. So it's an inconvenience, but it is such a minimal inconvenience compared to the risk, particularly of some older folks that may be in the congregation, people that are at increased risk for severe illness. Those are the folks that I think we need to keep in mind and take the higher ground and do the right thing.
Thank you, Dr. Ball. We've got another question from Facebook. This one's from Diane. With 5 to 11-year-olds recently became eligible to be vaccinated. So those 5 to 11-year-olds that have just gotten 2 doses of the mRNA vaccine, can they feel or consider themselves protected enough from the Omicron variant, or will they need to wait until they're eligible potentially for a booster sometime later on? Perhaps Dr. Hahn, you want to take a?
I can certainly take that. Yeah, I think a couple things. First of all, right now, boosters are not recommended in that age group. And they've so recently started getting vaccinated that none of them would be eligible, even if you looked at the criteria for older, children and adults. So I think for right now, and I guess the last part of the question I'll say quickly is we don't know. The question of are they protected enough against Omicron? As we've discussed, we know the current vaccines are not going to be as protective, although early on they do look good. When in a lab setting, at least when they looked at antibodies from people that had been recently vaccinated, they actually had strong protection. It just tended to fade off really quickly after some time. So 5 to 11-year-olds are probably looking pretty good right now for protection from Omicron, and only time will tell. Just stay tuned. Certainly a lot of physicians, epidemiologists, public health agencies will be looking closely at whether there's a need for booster in that age group down the road.
A question, I guess a follow-up question about vaccines, given the news yesterday about the Johnson & Johnson vaccine. The CDC recommended that the 2-dose vaccines, Moderna and Pfizer, should be preferred over the Johnson & Johnson shot due to a very rare but serious health disorder linked to the J&J vaccine. What does that mean? What does that news mean for Idahoans who already received the Johnson & Johnson vaccine?
Yeah, I'd like to take that. I don't know if others want to weigh in, but I was on that meeting yesterday and heard a lot of discussion. So I'll just say, first of all, for those that receive the single dose Johnson & Johnson vaccine, we do recommend you go as long as it's been at least 2 months, which by now for most people it certainly has, because it was used mostly last spring and not so much since then. Go get a booster, and that should be either Pfizer or Moderna. Go get an mRNA dose because really there's a couple things. One is that the vaccine was never quite as effective. It was good protection, but not as strong as the mRNA vaccines. And we recommend boosters for everyone, including people that got Johnson & Johnson. So that would be the first thing. The second thing I want to make sure and address is that side effect that was reported. And I wanted to bring this up anyway, because it's so fresh in my mind from yesterday's meeting. When people worry that we're not paying attention, as Dr. Pate was alluding to, we're not paying attention. There's all these deaths and nobody's tracking it and nobody's responding to it. This change in recommendation was based on 9 deaths that were confirmed to be linked to Johnson & Johnson vaccine. On the basis of 9 deaths nationwide, after millions of doses, I think they said 16 million doses of Johnson & Johnson have been delivered. That was enough for this committee to meet an emergency session yesterday after those 9 deaths were all totaled and confirmed, to say, okay, that's serious enough that we recommend people get the mRNA vaccine over the Johnson & Johnson vaccine. Now, for people that already got Johnson & Johnson vaccine, this side effect is seen pretty quickly after vaccination. So don't fret that, oh my gosh, I had that vaccine back in June. Is something going to happen to me? This is a much more immediate side effect. It does not occur months later. This is something that, people shouldn't be worried about it, but they should seek a booster just to get a good protection. And going forward, for most patients, they'll want to consider Pfizer, Moderna over the Johnson & Johnson vaccine.
Thank you, Dr. Hahn. We're getting close to our hour mark, but I'll try to fit in as many more questions as I can from you all in the audience. Here's one from Kelly on Facebook. If you are vaccinated, boosted, and contracted a breakthrough case, and also immunocompromised, any suggestions to help revive smell and taste? My daughter is a 30-year-old healthcare worker. She got COVID from her unvaccinated boyfriend after working with COVID patients for 2 years. Yeah, so any recommendations on reviving smell and taste?
Yeah, I see Dr. Pate shaking his head. I'll let him answer. I have another thought, though. Dr. Pate, after you answer, I want to make a comment.
Yeah, I was just going to say tincture of time. I'm not aware of anything that you can do to, a lot of things have been touted out there. I'm not sure there's evidence that any of them work. I think it's just a tincture of time, and it can be a long time. And I think, as we talk about, the risks of getting COVID, let's not completely focus on deaths. There's a lot of bad stuff that happens. And you might think, oh, loss of smell, how bad can that be? It's a big deal for people. In fact, it changes your taste of food, and you can lose that anyway. But even if you just can't smell, then food doesn't taste as good. We've seen people that have got this as a post-COVID effect that are losing dramatic amount of weight because they don't want to eat. So it's not a minor thing, but it's a tincture of time unless Dr. Hahn knows of a remedy. I don't.
Yeah, I don't. I will comment, there are physicians that I think are gaining more clinical experience with patients like this coming in and asking about it. I agree. I don't think there's been a successful proven treatment, but I think it's certainly she should check with her healthcare provider. There may be some new treatments coming down the pike. But the question about immune compromise, I just want to make sure, I don't think we've mentioned this yet on the call. I want to make sure that the listeners and folks are aware that there are some monoclonal antibodies that we're expecting to be available, not in large number initially, but hopefully eventually a lot, for immune compromised people that are kind of like, I use the analogy of when you used to go to travel and you'd get the gamma globulin shot in the butt, that would keep you from getting hepatitis A virus infection. You were giving somebody antibodies and that had this long protection for about 6 months. There are antibodies that are expected to be available soon that will do that type of thing for severely immunocompromised people that don't respond to the vaccine. So transplant patients, cancer patients on chemotherapy. So stay tuned. Those will probably be available in Idaho soon and around the country, but in limited numbers. But we're hoping that there will be more and more over time.
A question from Tiffany in Boise, who asks, I've heard from 2 lay people that a recent recovery from Delta does not provide protection or immunity to Omicron, for Omicron. Is that true?
Yeah,
Let's just qualify it. It provides less protection. You may or may not be protected from it, but the early data suggests it's not going to be as much protection as you had against the prior variant. So you still, if you got COVID, even if it was Delta, you, like Dr. Hahn said, you need to really give consideration to go ahead and get vaccinated.
I guess a follow-up question about that and the vaccines. One thing that we're seeing now in much of the country is the cases are rising again, even in areas with comparatively high vaccination rates. So what do we know currently about how vaccines affect transmission versus severe disease and death?
Yeah, I'll start, and the others might want to weigh in as well. But I think this is a challenge. I think we were hopeful when these vaccines came out. We were hopeful that not only would they provide individual protection, which they do, but that they would also help provide sort of a community immunity or even a herd immunity, whatever term you want to use. And what they're showing us so far is our current vaccines do protect you individually, which is probably the most important function we want it to do. It protects you from landing in the hospital, protects you from having severe outcomes in most cases. Most people are well protected. But we are not seeing a lot of community benefit. You can still get the infection, you can still transmit it. We think at lower numbers. Most household studies suggest they look at folks that get COVID and see how many folks they spread it to in the household. And most studies have suggested that you are less likely to spread this to others, even though you can get virus in your nose. And yes, you can still transmit. Those are true. So most people that study this say we're going to need different vaccines. We're going to need probably better vaccines that can actually prevent transmission, not just protect us individuals, but help us protect the community better before we can really hope to turn this around. And that's why it's so important for us individually to get vaccinated. We can't rely on, hey, it helps, but it's not 100% that you're going to be protected by others being vaccinated.
Here's a quick question from Sarah. Is data showing any preference for mix and matching strategies with COVID vaccines for more complete protection? With booster doses, I imagine that's speaking to.
I'll start and let if others want to chime in. So basically, we don't know. What we know is from the National Institutes of Health has done some studies and is working with partners around the country. Mix and match, folks, we know that it is safe. and we know that they get antibody response. So it is considered allowable. Theoretically, it's worth considering because you do get maybe a slightly different response from each of the two vaccines that might help broaden or strengthen your response better. That said, right now, according to CDC, about 95% of people that are getting boosted are kind of staying with their same vaccine. And everybody I've talked to says, well, I did okay with my first 2 doses. I don't know if I want to change horses in the middle of the stream right now. So most people are sticking with their current whatever they got in the beginning. They're getting boosted with that. But there are studies ongoing to actually look at the level of protection and whether you actually have better protection with a crossover. And we will eventually know the answer to that.
Well, I think that's probably all the time that we have. Thank you so much, Dr. Hahn, Dr. Pate, and Dr. Ball for sharing your perspectives and what you know with us today. And thanks to all of you watching at home and asking thoughtful questions. You can find the Statesman's coverage of COVID-19 at idahostatesman.com/coronavirus. Again, I'm Ian Stevenson, a public health reporter at the Statesman. Our newspaper's ability to keep covering the pandemic and keep keeping you informed about matters important to your health relies on your support. If you like this event, please consider supporting local journalism by subscribing to our paper at idahostatesman.com/subscribe. Thanks again, everyone. Stay safe and healthy, and happy holidays.